So, hi to everybody. I'm so excited to be here with my friends and colleague, Dr. Katherine Warburton and Dr. Steven Stahl. And we want to present for the first time to the public Icon. So, let me put this first slide. So, Icon is the International College of Neuroethics and Neuroscience. And I'm Professor Father Alberto Carrara. I'm an expert in the field of neuroethics, the field that want to bring together the reflection, the anthropological reflection dealing with neuroscience and the interpretation of neuroscience. So this is my introduction to the first ICON webinar. Um, what happens when we collectively neglect something so crucial, so fundamental to the human experience? Think about it. What happens when we as a society decide to turn a blind eye to something that undermines our very essence as conscious being? This isn't a question for a philosopher like me in a lecture. It's a reality, and it is unfolding right now. Today, we are not talking about some dusty story from the annals of history or far off dystopia. No, we are talking about something real, a lived experience that affects millions of people, millions of vulnerable people, people like us who suffer silently as a society, move on, distracted by other concerns. This is not an abstract tale. This is a crisis, a real crisis, a crisis that tears apart lives, families, and communities in real time. And it's happening to those who need our help the most. We are here today to address something far more insidious than a mere medical condition. We're talking about schizophrenia, a neurodegenerative disease, one that goes beyond just affecting the brain. It knows a person's very being, slowly and cruelly dismantling what makes them who they are. This is a disease that distorts the very concept of personal identity and self awareness, eroding the connection that tethered us to reality, both within ourselves and in our relationship with others. Imagine not being able to trust your own mind or feel at home in your own body. Imagine living in a state where your thoughts, actions, and sense of self slip beyond your control. That is the brutal truth of schizophrenia. It is not just about psychosis and delusions, as it is so often misunderstood. It is about losing the most basic ability to be aware of oneself, of others, and of reality itself. A life of fragmentation, a life of isolation, a life where the very core of who we are beings to unrevealed. But here is where it gets interesting because science offers us hope. In the last few decades, we have made remarkable strides in understanding neurobiology of schizophrenia. We have developed effective treatments that can alleviate symptoms, slow down the progression, and help patients regain some sense of control over their lives. As we are going to hear today, neuroscientific data is clear. These treatments work. Medication, therapies, interventions, they have the power to improve lives, something dramatically, sometimes dramatically. And yet, for all this progress, there's a catch, and it's a big one. Despite the breakthrough, despite the knowledge we have, this part of the story, the part where we actually make us of what science has discovered, remains unrepresented, unfounded, largely ignored, even for policymakers. It is as if we have found piece of a puzzle, but can't be bothered to put them together. The story of schizophrenia for many remains incomplete because society still isn't listening. And that brings us today together. And you see, schizophrenia, despite the mounting evidence and solution we have at hand, remains a disease that society struggles to engage with fully. We shy away from the tough conversation, from the hard truth. But here at ICON, the International College of Neuroethics and Neuroscience, we are not here to sugarcoat or look the other way. We are here to tell the part of the story that really gets the spotlight, the part that forces us to confront uncomfortable realities. Today, we are going to hear about why we are failing millions of people who live with this disease and why it is on all of us to do better. Because the truth is, this isn't just a medical issue, it's a social one, an ethical one, a neuroethical one. This is why ICON exists, and this is why you are here today. So buckle up. We are about to delve into the uncomfortable, the inconvenient, and the often neglected truth about schizophrenia. And hopefully, we by the end of this, you will see why ignoring it is not longer an option. So let me introduce Dr. Katherine Warburton. So Dr. Katherine Warburton is a statewide medical director of the California Department of State Hospital. Then I visit the California State Hospital uh, next last June in Napa Valley, and which has over, I guess, 6,000 beds and is the largest forensic inpatient system in the country, I guess. She's an associate professor on the clinical faculty within the UC Davis Division of Psychiatry and the Law, and is board certificate in psychiatry and forensic psychiatry. So, Dr. Wabutu, thank you so much. And she's the founder of the ICON, and she's our brain in this sense. So, you have the floor. Thank you.
Thank you, Father. I think I best explain myself if I tell a little bit of the journey that I've been on as a psychiatrist in my career. As a young psychiatrist, my real passion was working with people who have psychotic illnesses, specifically people who are so delusional that they're not participating in the same reality as the rest of us, and who hear and see things that aren't there because of the way their brain perceives stimuli. And was planning to just work in communities with this population. And as I got further into my training, I realized that would be impossible because these patients are not in the communities in the United States. Or when they are in the communities, they're living on the open street. But more often, they're cycling in and out of jails and prisons and forensic hospitals. And that's why I did forensic training, because so many of these individuals have wound up in our criminal legal system here in the United States. So as I've progressed in my journey, I've recognized the role that policies play in that tragedy, that humanitarian crisis that's happening in the United States. We did take our founding members of ICON through a neighborhood in San Francisco this summer so that our friends could see for themselves the tragedy that's occurring in this country for people who have these diseases. So as we've kind of delved into this, we've looked at policies all around the world, throughout the United States, Australia, New Zealand, Italy, Ireland, and we've come together to try to inform policy as experts in this disease and experts in neuroethics, experts in policy, because this is largely an issue that's policy based on misunderstanding about this disease. So it affects about 1% of the population, but it's much more significant number of jail populations, prison populations, and people who are unsheltered in this country. So my mentor, Dr. Stahl, and I have been frustrated as we've watched policymaking happen in this country. And we were so frustrated that we sought divine help in the form of Father Carrara to help us understand some of the neuroethical issues that underpin people's beliefs about these diseases and the beliefs that inform some of the policies that have resulted in these tragic outcomes. And what we've finally come to as a group is the best way to approach this problem is to educate people. There are just so many misunderstandings. Someone on a street corner screaming at something that's not there, suffering. There's so many misunderstandings about what's going on with that person and why. Why are they on the street corner? Why aren't they treated? Is this, a lot of people think it's just people abusing drugs or making a choice, and these individuals are not making choices. So the purpose of Icon is to bring together expertise in the biology of this disease, expertise in the history of the policy for treating this disease, and expertise in neuroethics, so that we can just educate. And through that education, hopefully inform policies that improve conditions for these individuals worldwide. And so I think to start the education process, the most important thing is for people to understand the biology of this disease, the treatability of this disease, the gains that we have made in the science and understanding of schizophrenia over the last 50 years. And fortunately, we have the world's most famous neurobiologist on Icon, and that is Dr. Stephen Stahl. And I would love to turn it over to him to explain a little bit about what we now know about schizophrenia.
Well, thank you, Kate, and thank you, Father. Let me tell you about a little of my journey before I get into the specifics. I started out as a freshly minted MD, PhD, interested in neuropharmacology, which is the study of medications and how they work in the brain, their mechanism of action. And so I studied serotonin and other neurotransmitters and spent a career actually looking at some of the new medications to treat various disorders across psychiatry. And I became what's probably better known as a psychopharmacologist. I'm kind of interested in all the drugs that treat all the psychiatric disorders, from mood disorders to anxiety disorders to psychosis. And I was purring along merrily in my way, going up the scale academically and getting grants and so forth. And I suddenly realized that I was in a bubble. And my bubble is a group of people who work in the same field and think similar to myself. And I thought everybody knew that schizophrenia was real. It was an illness. It was a brain disease. And that there is a very good and reliable way to diagnose it. And we know what's going on with the brain. And we know that medications work in the sense, I'll give you some more details here in a second. And come to find out, there are a number of policymakers who believe that this is not an illness, that it's a fantasy, it's something made up by mental health workers for evil purposes. It's also got medications that are only terrible to people. They hurt them. They don't work. And so people should have the choice, if they're called a schizophrenia patient, to not say I'm schizophrenic and to refuse treatment. And that treatment, even if it leads you to eating out of dumpsters and getting cycled in and out of prison and jail for the rest of your life, that's fine. So it turns out that untreated schizophrenia is not benign. And even though Kate already told you about 1% of the population, let's say in the United States, it'd be 3 million or so people have this illness. Some of them are early in the illness and they're not as difficult to treat and they're not as sick. And one could argue, well, are you sure it's schizophrenia? Are you sure that the medications are going to work for this person and the risk benefit is good for them? And there's some people that have mild illnesses. It's not unlike cancer. If you treat illnesses early, they don't get worse. Well, in our case, schizophrenia is largely neglected. And so I'm sitting here making these new drugs essentially on a big team of people from all over the world, other scientists, other clinical investigators, the drug industry, and figuring out it doesn't matter. Nobody's going to use these medicines anyway, because all they do is refuse them. And the policies in the United States allow people on a whim to refuse them, unless they really are so dangerous that they're imminent to actually do something to themselves or somebody else, like in the next 5 minutes. If they just did it a few hours ago and they say, well, I won't do it again, then they don't need to be treated. It doesn't make a lot of sense. And as Father is teaching me this, basically you're losing part of your humanity when you can't make decisions because you're too sick to know you're sick. And so I thought, how could somebody refuse to believe this is an illness and that the medicines work? And it's like, oh my gosh, this doesn't make any sense to me. And so I joined the state hospitals 10 or 12 years ago under Dr. Warburton's directorship, and was just astounded. These people that we're treating are the simplest ones to actually make the argument that they need treatment. They're at the end of their illness. They've often had what we call a duration of untreated psychosis for most of their time since diagnosis. They've been in and out of facilities, and they finally essentially earn a place in our hospital because they commit a felony, and they're very sick. And so now that's how you get a ticket to being treated at the end of your illness. If you treat stage 4 cancer, it doesn't get as well as if you treat stage 1. Anybody gonna object to that? Well, they don't, but they sure will object to the fact that, if you neglect schizophrenia, it doesn't matter. Well, let me tell you, schizophrenia is a brain disease. It's both neurodevelopmental and neurodegenerative. What do I mean by that? Well, something goes wrong with the neurogenetics of the brain in the formation of connections, synapses. And it, funny enough, remains pretty silent. Maybe some odd behavior or some less than full cognitive, abilities, but then erupts into a break, we call it a psychotic break. Almost 100% of such people are hospitalized. And it announces itself. Hey, I'm here. This is the illness. I've got it. And so what is going on? Well, we believe that the development of connections is being restructured in everybody's brain. All of us, any human being has a restructuring of their brain in the range of 12 to 20 years old. And did you know that half the connections that your brain makes in the first 12 years are actually destroyed by the brain in normal brain development? It's maybe God's way of saying we're going to make an insurance policy to make sure you've got so many connections that you don't even need them all. And if you lose a few, it's not a problem. But it is a problem in schizophrenia because the destruction of synapses is wrong in this era. They destroy the wrong ones, the good ones. And then you're left with this syndrome, which is easy to diagnose and not controversial. There's science behind the validity of the concept of schizophrenia as a brain disease. and it can be, whether you use the American DSM Diagnostic and Statistical Manual, you use the European ICD International Classification of Diseases, they're synonymous with each other by and large. You can actually, through the symptoms that people have at this age, when they have their first break, diagnose this illness. Now, the course of that illness is variable, but I don't know. I think that we would say that at least 1/3 of the people are PDS. The young doctors say this is Stahl's criteria. It's not a real criteria; it's just a joke, but it's called pretty darn sick. So there's schizophrenia globally, and there's schizophrenia PDS. Now, that third of people is going to not do well without treatment. Their brain is going to now go into a neurodegenerative phase. So after the disease announces itself, in some ways, all of us here on this call are developing their brains every day. So there's a constant neurodevelopment of us till death. That's normal. Well, in schizophrenia, I already told you their neurodevelopment is wrong. So it's tantamount to, if you're not developing, what are you doing? You're dying. And your brain is literally on fire. And you can show this very reproducibly with brain scans. And so you can actually see the brain essentially degenerating. The brain loses its tissue. It gets smaller. It goes away. And it's degenerating. It takes 20, 30 years to do that. And so we have proof that this not only happens, but it's proportional to what they call the duration of untreated psychosis. Now, if treated psychosis slows or halts this, and untreated psychosis inevitably goes to more loss of brain, why wouldn't you treat it? I don't know. It just seems to me that more brain's better than less brain. I'm not really that smart a guy, but it would seem like that wouldn't be too difficult a leap of logic. And indeed, we can prevent this progression of the brain rotting by treatment. We wouldn't do that to a cancer patient. And what we do is we neglect these people in their 20s and 30s, their brain's on fire, and eventually they get to the point where they hardly respond to medications, and they hardly respond to the general interventions that you make psychosocially. So they get arrested because they commit crimes and they bother society, and then they go into jail where they do get treatment. But they only get treatment till they basically are, if you will, restored to competency, and we would say their humanity is back, and they're on medicines and they get discharged, and guess what happens? They stop treatment. And society says, that's okay. It's your right to do that. We don't care. We're not going to create any structure so it's easy for you to get treatment. We're going to let you stop it because, who cares if you're eating out of a dumpster? That's your choice. Well, is it really somebody's choice if they don't know that they're sick? And that's the problem. One of the unique characteristics that's probably not present in very many illnesses is called, are you ready? Anosognosia. What's that mean? It means I don't even know I'm sick. I don't even know my medicines work. And so it's a lack of insight. Schizophrenia has lots of places where it lacks insight, but one of the most important is that you don't even know you're ill or that the treatments work. So you're not motivated to take it. Who wants to have schizophrenia? You want to stand up and say to all your friends and family, oh, I got schizophrenia and I need to take an antipsychotic. Nobody wants to do that. There's a lot of stigma against that. So people want to say, hey, I'd rather not be sick. I feel good. And guess what? It takes 6 months to relapse after you stop your medicines. So for a while, you're whistling through the dark. And meanwhile, your brain's degenerating very slowly over that period of time. And the next psychotic episode maybe burns out even more neurons during the psychosis. And when you recover with treatment again, you're not restored to integrity. You're a little bit lesser than you were before. And on and on and on. And so society only really takes matters into their own hands when I began to see them at a late stage in my career in the state hospital systems. These were patients I never saw as a resident or treated in a VA hospital or in a general clinic. These people are the end stage of neglect. It's stage 4 cancer, if you will. And so What's wrong in the brain? Well, one of the things is you can do a type of scan called a PET scan, positron emission tomography. You can literally see how much dopamine is being released in a very critical brain area. And you know what? It's been well replicated that in schizophrenia, too much dopamine is coming out of a specific area of the brain. That doesn't happen in mood disorders like depression. It doesn't happen in anxiety. It's not non-specific. It's very specific to the state of psychosis. And so when you're psychotic, this dopamine is being released. So we know that there's actually a really clear biomarker for this illness. It's not up to some argument. When you're psychotic and you actually aren't medicated and you go into a brain scanner and you look at it, you're going to have dopamine pouring out of the brain. Indisputable. And so why wouldn't you want to stop that? Because we do now know that if you stop that dopamine from coming out by blocking its effects, it's called a drug that treats psychosis. And we're beginning to say this is a drug that restores dignity. This is a drug that's disease modifying. What do I talk about that? Well, if you get your insight back and you actually are capable of understanding whether you're sick or not and whether your treatments are working, that's a pretty big deal. And so that's one of the side effects, if you will, of medication. It's a good one, but it's, that's what they do. And so do medicines work? Well, we've looked at this and you're not going to believe this, but I'm going to tell you anyway. You ready? Antipsychotics have an effect size bigger than the ability of statins to prevent progression to cardiovascular events. They work better than that. Not only to actually treat patients that are psychotic, but to prevent relapse. Antipsychotics work better than aspirin works to prevent second heart attacks. Drugs for schizophrenia work better than aspirin. And drugs for schizophrenia also work better, for example, than metformin does to prevent progression of diabetes. Now, no one would argue that those three drugs for diabetes, hypertension, stroke, cardiovascular disease, and cholesterol, nobody would argue that you shouldn't take them. Nobody's going to argue there's no such thing as hypercholesterolemia. There's no such thing as a heart attack, and the drugs don't work. So why in schizophrenia they say there's no such thing as a neurodegenerative illness? There's no dopamine problem in the brain. That's just crazy. Doesn't exist. And the medicines don't work. But you know what? When I got out of my bubble, I found all these people saying that. I'm going, what the heck is going on? How can these do? And so we have to assume that the people who are saying that are intelligent and well-meaning. And if we just show them the evidence, and I can show you slides and we can make a data presentation to convince you that, yes, this is an illness. And a third or so of the people with that diagnosis, at least, will progress to a point where they are going to commit crimes and be unable to function, and that it could have been slowed and if not prevented. And guess what the worst part of not treatment is in schizophrenia? Premature death. People with schizophrenia that aren't treated die about 20 years early. Why? Because their disease progresses. They don't care of their body. They have cardiovascular issues, underlying health problems, and they die. And guess what else? That's not even the biggest cause of death of schizophrenia. Do you know what the most important thing that drugs for psychosis do for a schizophrenic patient? They prevent suicide. Up to 15% of patients will die of suicide. It's a horrible disease. People don't want to have it, and they just get sick and tired of it and kill themselves. So why would you stop a person from being able to get his brain from not degenerating, his life from being 20 years truncated by poor health, and killing yourself? These are such stunning effects of treatment. It's actually unconscionable to me that we have opposition by policymakers who say you should have the choice of being able to stop your medicines or not take them, even when you don't know that you're sick, and even in a state of acute psychosis. So I'll end this by saying it's been an interesting journey, and I'm honored to actually pursue this with policymakers like Dr. Warburton and neuroethicists like Father Carrara, and try to provide some of the science and the data behind the fact that I am so confident that this is a real illness and the medicine really work, that they can get that. So we now need to get this. And I'll also anecdotally say, you know what? There's a new medication for psychosis about to be approved as of the time of this recording, and it works by a brand new mechanism and gives brand new hope that either it will work better or be better tolerated, or when added to the old medicines, work more powerfully. And I was beginning to say to myself, will it even matter? Why spend your time going after new medications if no one's going to use them? Because the policies don't connect the patients with this unmet need. Thank God for my colleagues on this call, because they're going to take some of the data and try to use that as a way to communicate, to convince people that it's not only ethical, but it's mandatory, and it is good human common sense to go ahead and try to treat this illness.
Thank you so much for that scientific explanation of this illness. And so as you're listening to Dr. Stahl, you begin to wonder, why aren't people being treated? And how does policy play a role in this? And to answer those questions, we've done a number of things. One is we've read the entire history of psychiatry, anything that we can get our hands on. And the other is we've traveled the world looking at other mental health systems and other outcomes for people with this biologically based neurodegenerative condition. So just briefly, if you look at the history of psychiatry in the United States, you can understand why people don't trust the science of psychiatry. There is a past that we have to own and acknowledge of people being indiscriminately locked into institutions in this country. There have been experimental treatments such as frontal lobotomies and insulin shock comas that are reprehensible and difficult to justify. So as psychiatrists, we need to own that. In the United States, prior to the mid-1800s, people who had psychotic brain diseases were oftentimes locked in cages or chained to walls. The lucky people were locked away in a room in their family's home. The disease was not understood. Some people thought it was a moral failing or a spiritual condition that was causing people to not understand reality and to hallucinate. And in the middle of the 1800s, globally and in this country, the inhumane conditions of these individuals were brought to the attention of state legislatures by a woman named Dorothea Dix. This is a sideline, but when I was in 8th grade, I grew up in the state of Maine, and we had to write a report on a famous Mainer. And there are not that many of us, so it was slim pickings, but I picked Dorothea Dix, who was born in a little town just across a river from where I was born. So I have a deep connection to this heroic, historic figure. But she would travel the country, document these inhumane conditions, and write reports to the legislature, basically shaming them into doing something about these conditions. And so she was credited with reform in the form of building beautiful asylums. And she was credited with the creation of over 30 asylums in this country. And the asylums were considered to be the answer to those inhumane conditions of people being chained to walls, et cetera. And they were built in a beautiful Gothic style. They were castles. The doctors lived there, the nurses lived there, the patients lived there. They exalted in nature, and the treatment was considered or called moral therapy because it was considered to be most important, just to care for these people in a humane, kind, compassionate way. And if you read what the psychiatrists were saying back then, they thought they'd solved the problem. They were quite convinced that the asylums delivering moral treatment would be the answer. Unfortunately, in this country and around the world, the asylums became what were called snake pits. Over the next 100 years, there was no accountability on who was institutionalized, locked away. There was no accountability to resource these facilities to accommodate these growing populations, and they became overcrowded, decrepit, and shameful. And so starting in the middle of the last century, a movement called deinstitutionalization happened, where here and around the world, there was a recognition that we could not lock these human beings away in these institutions under these inhumane conditions. So the inhumane conditions from the middle of the 1800s were replicated in the middle of the 1900s, just within the walls of these asylums. So asylum went from being a good term with a positive connotation. Now when we think of asylums, we see visions of people huddled together in really squalid conditions. So deinstitutionalization, in my analysis of international policy, is where the different policy decisions made by different countries are resulting in very different outcomes. And in the United States, deinstitutionalization was enabled by, it started here in California, something called the Lanterman-Petraeus Short Act, but it was enabled by policies that made it impossible to involuntarily treat anyone unless they're dangerous. So in the United States, you can have a young, healthy, vibrant young person whose brain starts to deteriorate. They can become paranoid and start hallucinating and hearing voices telling them things. Oftentimes we see young people being paranoid about their family, erroneously misinterpreting reality to think that their family is trying to harm them. And so they move out of the family home and out into the street, but they don't have any resources because they've cut off ties with all these people that they feel paranoid about. So they're impoverished and they're starving. And because they're starving, they are literally eating out of the trash. And they're on the street corners, screaming at the voices in their heads, suffering, tormented by their symptoms of psychosis. But if they're not dangerous, there's nothing that we can do. And you can hear the stories of the parents of these children when they try to bring the child to care in the emergency room or at a clinic. And when the young person says, "I don't want your medications, you're trying to poison me because you're in the CIA and you're after me," everybody in the mental health system says, "Well, there's nothing we can do. They're not dangerous." And so it's like this dangerousness standard for treatment enables the abdication of responsibility for these patients. And I shared this anecdote with Dr. Stahl a long time ago. I can remember having very, very sick people brought into the emergency room in the middle of the night when I was a resident on call. And if that person said, "I'm not going to hurt myself or anyone else," we would let them walk right out the front door. And I remember feeling guilty because then I could go back to sleep and I wouldn't have to work up that patient and find them a hospital bed and be up all night. And I think that experience of relief at abdicating my responsibility for that human being, even though I was a doctor, I think that's a metaphor for the way our system in the United States operates today. And, you know, Dr. Stahl pointed out something very important. It's now scientifically proven that about 60% of people who have schizophrenia are not aware that they have schizophrenia. They believe the things that they believe. So they do believe that people are out to get them, or they're in a war for the soul of the world. I mean, these people have very intense and elaborate beliefs about what's happening to them that don't include the belief that this is a product of their brain disease. So other conditions have that. Alzheimer's, dementia, you can have a lack of awareness that you're sick. But if someone who has Alzheimer's dementia needs to go to a memory care facility because they've been wandering around without their clothes on and walking into the street, which is not atypical for someone with dementia, we put that person in a memory care home. We don't say that person has the right to walk in traffic. We say this person is sick, they don't know that they're sick, and they have a medical necessity for treatment, and so we're going to treat them. And we don't get into the debate about whether that's coercive or cruel. We understand that that's compassionate and medically necessary. So why do we treat this disease differently than other brain diseases that also cause a lack of awareness and behaviors that are not in the best interest of that person? So that's a long story about the history, but the current history now, and this is how I got involved in this mess, the current history now is that individuals are in the United States unsheltered, untreated, and getting arrested because their symptoms of mental illness are being relabeled as criminal behavior. And when someone who is very, very psychotic and is not participating in consensual reality is arrested, it's considered unconstitutional to have that person stand trial because they don't understand what's going on. So they get sent to a state hospital to be medicated so that they are now reality focused and their symptoms of delusions and hallucinations go away. And then it's considered constitutional for them to stand trial. And so that can be used as a proxy, essentially, for someone with schizophrenia getting arrested. This incompetent to stand trial population is really largely people, and we've done a ton of research. I have all the science on this. This is largely people who are psychotic. Oftentimes what we'll see is they'll be screaming on a street corner, making people uncomfortable. So the police get called and they get charged with trespassing and resisting arrest, or trespassing and assault on a police officer. So they get that big felony charge due to their interaction with the police officer, because of course they are delusional and they don't understand that the police officer is a police officer. So it's a complicated situation that I hope I've explained adequately. But the bottom line is these populations, this population of people who have schizophrenia who are being arrested is skyrocketing. And it's been skyrocketing for the last 10 to 15 years. And it's a crisis in the United States. And that's how I started down this road of looking at policies. It's a crisis in the United States because now, 100 years after deinstitutionalization started, we're reinstitutionalizing people. And they're now in big forensic hospitals, like the one I took you to, Father Carrara in California, or they're in prison, or they're in jail, or they're on the street. And that's the outcome of deinstitutionalization in the United States that was enabled by a dangerousness mechanism. So we started talking to our friends in other countries, and actually we went to see Father Carrara with Dell'Iconn 2 years ago when we formed as a group, and we toured the mental health system in Puglia, Italy. And it was a completely different situation. It was unbelievable. They have no state hospitals in Italy. They've been outlawed. They have no forensic hospitals in Italy. They've been outlawed. And most astonishing, I remember this so vividly, we walked into a prison with our hosts, and Dr. Stahl, being Dr. Stahl, said, "Why don't you bring me your patients with schizophrenia and I'll do some case conferences, you know." And the psychiatrist looked at him and said, "Why would we have someone with schizophrenia in prison?" And we were heartbroken, embarrassed, mystified. How could this be? And so we began to study the history of international policy post-deinstitutionalization. And we began to talk to our colleagues in New Zealand and Australia and Ireland and around the world. And so I would say, and I've studied this now, I have a binder here, this thick, of papers about the Basaglia law and the mental health system in Italy. But the bottom line is the Basaglia law outlawed state hospitals, outlawed forensic hospitals, but it also changed the standard for treating people with schizophrenia to a medical necessity standard, and they eliminated the dangerousness standard. In 1978, the Basaglia law did two things. It banned these institutions, but it also started treating schizophrenia like every other disease, where if you're very, very sick and you need treatment and you don't know that you're sick, we're going to treat you. And we don't say, hey, they're making a choice here. We're saying, hey, their brain's on fire and we need to treat this individual. So when we have this conversation, or attempt to have this conversation, as I have done a lot recently because of my new understanding of why the Italian mental health system is so successful, you are treated as if you are a cruel, inhumane person when you say that we need to be able to treat schizophrenia if people don't know that you're sick in the United States. And so that began the ethical conversation. Is it ethical to treat someone who has a treatable disease if they don't know that they're sick? Is it ethical to let someone who doesn't know that they're sick and is making really irrational decisions because they're delusional, is it ethical to let that person starve on the open street where they're abused by other people and end up being incarcerated? So we started looking at the ethics of this, and we fortunately had a well-known neuroethicist at our disposal. And so maybe, Father Carrara, I can turn it back over to you to talk about some of these ethical questions.
Thank you so much. I'm really inspired by this meeting, and also I really enjoy that we are work together, because I guess Icon has a great mission. And the question is why this topic is so important for neuroethics today. And neuroethics is a field related to a systematic reflection dealing with neuroscience and also the interpretation of neuroscientific data that start from 1973. And its origin can be traced to the need for a practical ethical framework to confront the misuse of neuroscientific intervention on vulnerable populations, such as in 1973, newborn babies. It was the field of Harvard neuropsychiatrist Annalise Alma Pontius. Back then, behaviorists and other professionals neglected the ethical dimensions of these interventions, treating these infants not as individuals with potential, but as mere subjects of experimentation. Neuroethics stood as a counterforce advocating for a recognition of each individual's inherent dignity, even in most vulnerable and voiceless stage of life. That same passion for safeguarding human dignity continues to drive neuroethics today. However, the ethical battleground has shifted, and we now face another form of neglect, as we heard, one that affects millions of people worldwide, those suffering from schizophrenia. Just as we once opposed the manipulation of newborns without concern for their future consciousness, we now confront a dangerous disregard for the neuroscientific data that could change the life of those with schizophrenia, as Dr. Stahl said. The stakes are just as high, if not higher, because this is not only about treatment of a condition, but about the very essence of what it means to be human. And schizophrenia is not merely a psychiatric disorder, it's a neurodegenerative disease that eats away at the individual's ability to engage with reality. The science is there, the data is clear. Early treatment can slow the progression of the disease, allowing individuals to maintain a level of self awareness, autonomy, and connection with the world around them. And yet, much like the behaviorists who once ignored the ethical implication of their actions in 1970s, some continue to neglect this data, leaving millions of people untreated, abandoned to life, fragmented lives devoid of the most fundamental human experience. The echoes of history are unmistakable. As neuroethics once stood against the unethical treatment of newborn, today it must stand firm against the neglect of those with schizophrenia. The neuroethical debate is not merely academic. It is about confronting the moral implication of denying treatment to individuals who are capable of benefiting from it. Failing to treat schizophrenia is more than a medical oversight. It is a profound violation of human dignity. It denies individuals their rights of self-awareness, their ability to understand themselves and their world. It strips them of their autonomy, their ability to live with a sense of control and purpose in life. Neuroethics reminds us that such neglect is not only scientifically irresponsible, but also, a very important, ethically indefensible. The debate is clear for me. The human rights to self-awareness, to consciousness, is inalienable. Schizophrenia, when left untreated, robs individuals of this right. The very essence of their humanity is compromised. And to ignore this fact is to participate in a form of, I call, passive abuse. The ethical responsibility is on us, on society, on healthcare professionals, of course, on policymakers to ensure that individuals with schizophrenia receive the treatment they deserve. We must move beyond the biases and the misunderstanding that surround this condition and embrace the neurological evidence that demonstrate the effectiveness of early intervention and sustained care. And neuroethics demands that we consider the full implication of neglecting these individuals. It calls on us to reflect on what kind of society we want to be. A society that values every human being, regardless of their neurological condition, or one that selectively chooses who is deserving of care and dignity. The lessons from 1973 should resonate loudly today. We cannot afford to be complacent. The science is there, and the ethical imperative is undeniable. Now is the time, I guess, for action. We must not repeat the mistake of the past. We must advocate for those who cannot advocate for themselves. And we saw them. We saw them in San Francisco. I saw them also in Los Angeles. And we must ensure that the treatment available for schizophrenia are not just a theoretical possibility, but a practical reality for every person affected by this disease. Neuroethics has always been a call to action, a reminder that science without ethics can be harmful. As also Pope Francis said, let us take up the call once again and ensure that no one is left behind in the shadows of neglect. The time for change is now, I guess, and let us act with the same urgency and dedication as those who pioneered bioethics, as Annalise Alma Pontius, that died in 2018 at 96 years old. Schizophrenia is not just a medical issue, it's a human rights issue. Every person deserves the right to be aware of themselves, to understand their place in the world, and to live a life of dignity. So, for this reason, I guess we create Icon, and this is the first uh, presentation that is going to be publicly present in English with Italian subtitle, and I'm very proud to be here physically with Dr. Stahl and virtually with Katherine. Thank you so much. And I'm very honored to be part of ICON as also member of the Pontifical Academy for Life, in which I'm in charge of the neuroethics group, research group, and also part of fellow of the UNESCO chair of bioethics and human rights, established in Rome in the Pontifical Athenaeum Regina Apostolorum and the European University of Rome. So thank you so much for this first webinar. Maybe we have to organize other webinar in order to spread our message, spread this hope for millions of people that are struggling, and to help society to understand the concept that we address today. And thank you so much.
Thank you.